The following podcast is part of a certified educational activity titled Mastering the Art and Science of Biologic Therapy for CRSwNP. Who are the candidates and how do you manage their care? Access the entire activity and complete the post-test at peerview.com/NMD860. Downloadable slides and practice aids are also available.
My name is Dr. Jivian Lee. I'm professor of rhinology and endoscopic skull-base surgery at the University of California, Los Angeles. We also have Dr. John Basso. He's a professor of allergy at University of Pennsylvania. So in terms of our learning objectives for tonight, we want to help improve your ability to recognize the signs, symptoms, and impact of CRS with nasal polyps on our patients. We also want to describe the various strategies to determine which of our nasal polyp patients are most likely to benefit from biologic therapy, give you some guidance on the appropriate use for targeted biologics in those select patients with nasal polyps, and then finally be able to enhance your ability to monitor the response of our patients to the biologics. All right, so again, my portion is going to focus on which patients with nasal polyps are candidates for biologics. Again, I'm professor at UCLA and also vice president of the American Rhinologic Society. All right, so just going over what is chronic rhinosinusitis. So, it's this inflammatory condition. It traditionally has multiple phenotypes, and in those simplistic form, we divide it into CRS with and without nasal polyps. I think the key thing in terms of the diagnosis is that you really have to have a combination of subjective and objective criteria. So the patient subjectively has to have at least 12 weeks of 2 or more of these symptoms. So nasal drainage, whether it be anterior or posterior, so rhinorrhea or postnasal drip. They have to have nasal congestion or obstruction, facial pain, pressure, fullness, and reduced sense of smell. But in addition to the symptomatic criteria, there has to be evidence of inflammation, and that can be verified either with nasal endoscopy, where we can see some drainage, edema, or the presence of polyps, or on a sinus CT scan, where we see evidence of inflammation of the sinuses. So if we look at the epidemiology, about 14% of adults in the U.S. have symptoms that meet the criteria for CRS. The typical age is usually around middle age when they're detected or when they become symptomatic. So it's usually between the ages of 40 to 60 years, or a middle-aged group or a little bit beyond that. It's more common in men, so 62% are in males and then 38% in females. But there have been some studies that suggest that women tend to have more severe disease, even though it's more common in men. So in terms of comorbidities, the risk factors are asthma, aging, and obesity. Some of the common comorbid conditions include allergic rhinitis, asthma, and NSAID or aspirin-exacerbated respiratory disease. And some of the symptom triggers include viruses, allergens, or the NSAIDs. So as I mentioned, in addition to subjective criteria, you have to have objective evidence that there is inflammation present. So here is your classic CT scan. You can see that there's severe disease here with opacification of the ethmoid and the maxillary sinuses on both sides. Here on nasal endoscopy, you can see there's polyps here with some mucinous debris. Then here another example where you see some polyps here within the middle meatus and some purulent discharge. So we included this slide basically to illustrate that there's multiple endotypes within CRS. So historically, we would divide CRS with nasal polyps as exclusively type 2, and maybe CRS with nasal polyps without nasal polyps as type 1. But it's actually much more complex than that. This is out of the study in Northwestern. You can see that there's a lot of mixed endotypes in the CRS without nasal polyp phenotypes, and it does include some T2, and the same with nasal polyps. Now, CRS with nasal polyps has garnered a lot of attention mainly because it has been shown to reduce our patients' quality of life, both physically and emotionally, actually. So in addition to the nasal symptoms I mentioned, they can also have symptoms of actually eustachian tube dysfunction or ear issues. That includes ear congestion, pain, and pressure. And actually, some of my patients are more bothered by the ear symptoms than they are by the nasal symptoms. And then in addition to that, it can cause a lot of emotional issues, anxiety, depression, problems with sleep. And this is just some bar graphs that illustrate that patients who have more comorbid conditions in addition to nasal polyps tend to have a worse quality of life than those without. So if we look here at the purple, these are the population norms. The scale is the SF36 quality of life instrument. The yellow here is CRS with nasal polyps, and then you can see how it's significantly reduced both in the physical and mental component in our nasal polyp patients. And then here, if you add some additional comorbidities, so this is CRS with nasal polyps and asthma, you can see it's worse than without asthma. And then this is our NERD patients. So if we look at sleep, there was a recent study that looked at 29 nasal polyp patients, and they were able to demonstrate that a significant proportion of them had a lot of issues in terms of their quality of sleep. So about a quarter had excessive daytime sleepiness, almost 80% had insomnia, and over 90% had some type of altered sleep quality. So it's definitely something to think about as we counsel our patients. Now, moving on to our traditional treatment approaches for our nasal polyp patients, really still starts with something as simple as nasal saline irrigations, which are over the counter. Also, there's a lot of evidence that long-term treatment with topical intranasal steroids is also very effective. And at least in the United States, which is great, we have a whole spectrum of delivery methods for steroids. So we have the traditional nasal sprays. We also have the exhalational delivery system that can give the high-dose fluticasone. We have the steroid-eluting sinus implant and also off-label steroid drops and rinses. Now, in terms of antibiotics, it can be useful for our nasal polyp patients if they have concurrent infection, but otherwise, I wouldn't say it would be first-line therapy unless there is a concurrent infection. Leukotriene modifiers like montelukast, also very useful, and then short-term systemic steroids, but of course we are limited by the side effects. So now when medical treatment is not successful, that's when our specialty comes in. We do endoscopic sinus surgery. And the goal here is not just to reduce the polyps and the inflammatory load, but really to try to make the openings of the sinuses as wide as possible so that we can optimize the distribution of postoperative topical steroid therapies. So with all the surgeries, you have to have some type of maintenance therapy with topical steroids in order to maintain a long-term successful outcome. So always think of it as like mowing a lawn. The polyps are the weeds. We mow the lawn with our lawnmowers, and then the steroid therapies helps to keep the weeds from growing back. Something I learned at Penn. So I did do my fellowship at Penn. That was a Dr. Kennedy Palmerism. So, all right. So, surgery is not always effective in the sense that you can have recurrence rates for especially those patients with severe disease or comorbidities. Historically, in some of the older studies, the polyp recurrence was close to 40%, but that was with some of the older, like where you just do a simple polypectomy. When you do more comprehensive surgery, some of the neuroendoscopic approaches, there was actually a study out of Penn that looked at the draft 3, where basically we combine the two sides together to create a really giant opening to the sinuses. The 2-year recurrence rate was actually less than 10%. Type 2 inflammation is associated with more severe disease and recurrence, which is where I think the biologics come in. And I'll talk to you about that a few slides later. But when we look at those patients with type 2 inflammatory comorbidities, really there's a lot of focus on asthma. So up to 65% of patients with nasal polyps have comorbid asthma, whereas the general population, it's only 8.5%. And it's usually adult onset asthma as opposed to childhood asthma. And as I mentioned earlier, if you have nasal polyps together with asthma, that endotype tends to have a lot more severe disease than somebody without asthma. And up to a quarter of patients, which actually probably even more, have comorbid NSAID exacerbated respiratory disease. So I know this is kind of a busy slide, and it's funny that this used to be so foreign to me probably 5 years ago before the advent of the biologics. But I really think, anyone who treats nasal polyp patients really has to be familiar with the pathophysiology. And the main reason is because the biologics target specific mediators and steps along this pathway, and there's going to be more and more that are introduced. So just to summarize, usually we have some type of insult to the epithelium of the sinuses, whether it be an allergen, even particulate matter, some kind of pollutant in the air, could be viral. They disrupt the epithelial barrier of the sinuses, and then you get activation of these type 2 inducers like TSLP, IL-33, IL-25. So we already have biologics on the horizon that target these specific mediators. These in turn bind to ILC2 cells, and then you get escalation of these type 2 cytokines, IL-4, IL-5, IL-13. IL-4 in turn increases IgE production. IL-5 activates eosinophils. IL-13 is involved in mucus response and remodeling. And again, the reason why this is so important is that each of these steps ends up being targets for the biologics. So here you can see the 3 biologics that are currently FDA approved for nasal polyps. We have dupilumab, which has a multi-pronged effect here because it's an antibody to both the IL-4 and IL-13 receptor. Omalizumab here, which is an antibody against IgE. And then you have mepolizumab. I think it's important to be familiar with this slide and really understand the pathophysiology, especially if you're going to begin prescribing biologics. So if we look at some of the other indications, I think this is why I think the biologics are very helpful for those patients who have comorbid conditions, mainly because not only do they have a severe or more severe inflammatory endotype, but you're really kind of hitting 2 birds with 1 stone. So with dupilumab, it's also approved for these particular comorbid conditions like atopic dermatitis, eosinophilic esophagitis, omalizumab for allergic asthma, urticaria, food allergies, and mepolizumab, eosinophilic asthma, EGPA, and hypereosinophilic syndrome. So this was a multidisciplinary comprehensive treatment algorithm for patients with nasal polyps. Was actually developed by both rhinologists and allergists that were members of the American Biologic Society, Quad AI. So both myself and Dr. Basso were part of this expert consensus statement that developed this algorithm. But really the first step, of course, is to establish the diagnosis that the patient has nasal polyps. So as I mentioned, once you determine that they meet both subjective and objective criteria, so that includes, again, either nasal endoscopy or imaging, then you move on and do the first line of therapy, which is still topical intranasal steroid sprays, or you can consider a burst of oral steroids as long as there's no contraindication or a combination of both. And then after about 4 weeks of therapy at least, you have to assess the symptom response. If the patient continues to have persistent disease, both symptomatically and objectively, I do think it would make sense then to try to endotype this patient. So you consider allergy testing, maybe have your allergist do an aspirin challenge, get a CBC with diff so you can get the serum eosinophils and a total IgE. And then if that fails, you can continue to do the high-dose fluticasone with the exhalational delivery system or consider doing another round of oral steroids. If the second round still is ineffective or the patient has persistent disease, then you move on to the next step in the algorithm. And I think in a minority of patients, if surgery is contraindicated, if they have poorly controlled asthma or steroid-dependent asthma, they decline surgery, then you can kind of move them to the biologic group and consider therapy in that arena. But otherwise, a majority of patients, we'd go on to do endoscopic sinus surgery. Now, there's a lot of discussion about the extent of surgery that should be done for the first-time patient. But ultimately, irrespective of the type of surgery that you do, you have to go on to do postoperative steroid management, as I mentioned. All of these types of different ways to kind of maintain your lawn, make sure the weeds don't grow back. And again, there's different ways of delivering the steroid therapy. And then if the symptoms still persist despite appropriate sinus surgery and postoperative topical steroid therapy, then you actually have multiple options at this point, and you kind of have to tailor it to the patient. It's really a shared decision-making process. So I usually offer all of these options actually to my patient. And then they help them to decide which pathway they want to pursue. So if the patient has comorbidities, you may consider biologics or a more aggressive revision sinus surgery if the initial one was more conservative. Aspirin desensitization for patients with ARD if they can tolerate it. The steroid-eluting implant, which is something that can be done in the office under local anesthesia, or you can consider another short burst of oral steroids. So if we're trying to determine, who to start a biologic on, again, you want to make sure to confirm the diagnosis that the patient has uncontrolled severe nasal polyps, someone who has failed medical therapy, appropriate sinus surgery, check for comorbidities, type 2 inflammation, talk to them about all the different treatment options, the pros and cons of each of the different alternatives, and then come to a mutual decision. Once you determine that you want to pursue biologic therapy, then you go ahead and select the appropriate biologic for that particular patient. Now, this is the EPOS euphoria criteria for biologic therapy. I just want to preface by saying that this was primarily for European patients. I was actually on this consensus statement as well. And the difference in Europe is they don't have all of the different therapies that we have, including, the high-dose fluticasone exhalational delivery system, the steroid-eluting implant. So we are in the process of trying to come up with one for America from the American Logic Society, as well as our academy. So again, you want to make sure that the patient has bilateral polyps, and then they have to meet 3 of the 5 criteria. So evidence of type 2 inflammation, and then these were the EPOS criteria, where tissue EOs greater than 10. So that's on surgical pathology. Blood EOs greater than 150, or total IgE greater than 100. A need for systemic steroids, so at least 2 courses per year, or long-term 3-month course of low-dose steroids. Significant impairment in quality of life, loss of smell, and diagnosis of comorbid asthma. Okay, so with that, I'd like to turn it over to Dr. Basso about selection of biologics.
Well, thank you, Jivian. You're at the point now where you've gone through the algorithm. You've decided that this patient merits consideration for a biologic. How are you going to approach this? What biologics are you going to use? What's the data? Let's go through some of that. So, shared decision making, obviously, Dr. Lee talked about that a little bit, really involves presenting options to patients, providing benefits and risk analysis to patients, assisting them, in evaluating these options because they may not understand the options, facilitating the decision making, and also assisting them, obviously, with implementing the plan. You're going to be discussing medications and surgeries, and comorbidities are really turning out to be a really important consideration for patients who you're considering for biologics. What are the symptoms? How are they affecting their lives? Will this patient adhere to therapy? What has been their rate of adherence if you're going to be putting them on some long-term therapy? And the cost, the cost not only to the patient, but the cost to society. I mean, if the biologics were less expensive, we would use them earlier. So this is something, but we're talking about patients who are pretty refractory at this point, and you're going to have to make some decisions. And again, you're making that decision with the patient. And when you make that decision with the patient, they actually have more confidence in you as a provider, and they will be more likely to adhere to your treatment plan. This slide was put up before. I'm going to spend a few more minutes on it, and that is, what are the other indications? So I always think about what the other indications are, because if you have a patient that primarily has severe polyps, but has one of these other indications, this may tilt you towards one biologic or another. So if a patient has severe atopic dermatitis that is poorly controlled with topicals, if you have a patient that has oral corticosteroid-dependent asthma or eosinophilic asthma that's severe, EoE, which is seems to be growing in popularity. I'm getting more and more cases of that. That's an inflammatory condition in the esophagus, and then prurigo nodularis, which is an extremely pruritic condition, which isn't that common. These nodular skin reactions, skin eruptions that are really, really problematic, and patients usually they can't sleep, and when they have that condition, It's really dramatic. And then eosinophilic COPD, or what we used to call asthma COPD overlap syndrome. I think that's kind of I think some of that's been renamed just for the thought of, the idea that biologics might help those patients. And then for omalizumab, which is the earliest biologic to be FDA approved back in 2003, it was first approved for a moderate to severe allergic asthma and later approved for chronic urticaria. We used to call it chronic idiopathic urticaria. Now we call it chronic spontaneous urticaria. And of course, these people are miserable. And back before omalizumab, there weren't really too many great treatments for people who didn't respond to antihistamines. So if they don't respond to antihistamines, omalizumab is used as an option. And then most recently, just this past year, for patients who have severe life-threatening food allergy, anaphylactic reactions to food, where it's difficult to avoid, there is the option of getting omalizumab therapy to give some protection against accidental anaphylaxis. In terms of mepolizumab, it's also FDA approved for not only severe eosinophilic asthma, but it's also FDA approved for EGPA, which can be very difficult to diagnose and something should always be on the radar when you're taking care of patients with eosinophilic respiratory diseases, and hypereosinophilic syndrome. Now, this is from the Liberty 52 study, which was the pivotal trial that got dupilumab its FDA approval. And you can see on the left is the improvement in nasal polyp score. That was very significant, the greatest actually of all the biologics in terms of comparison with placebo. And this is a 52-week study. And on the left, you can see there's about a 2-point reduction in the polyp grade. Remember that polyp grading, it's a nonlinear scale, and 2 points means 1 point for each side, but still was very, very significant compared to placebo, and as was the nasal congestion score, which was dramatically improved as well throughout the study. The other thing that was very noticeable is when they pulled the analysis of these patients is that 40% of the patients who were on placebo by a year were getting either surgery or oral corticosteroids, whereas only about 12% of the patients who were on dupilumab required either surgery or oral corticosteroids. And those patients who had polyps with concomitant asthma, which are some of the more difficult type 2 inflammatory patients, showed improvements in their FEV1 with about almost a quarter of a liter. And the ACQ, which is the asthma control questionnaire, showed a significant improvement as well. And there was a recent study looking at 3 years of sustained improvement with dupilumab in Germany, five-center study, 150 patients receiving 300 milligrams dupilumab subcutaneously. And what you saw is that there was no tachyphylaxis in the effect of dupilumab over 3 years. And so patients maintained their SSIT as a sniff and stick assessment of smell. They maintained their smell. Their polyp score stayed low. Their SNOT-22 improved. And the euphoria, the response, which is, I'm going to show you what the 5 criteria for response are. 75% of patients had good to excellent clinical responses. Harking back to a slide that Dr. Lee showed earlier, the effect on sleep is very dramatic. And then you have the Epworth sleepiness scale, daytime sleepiness assessment, the insomnia severity index, and the Pittsburgh sleep quality index. So these people don't sleep well when you have polyps. And what happened in the dupilumab intervention study is that there, as you can see, by 3 months out, there was a very significant reduction in the number of patients who had excessive daytime sleepiness, severe insomnia, and altered sleep quality. And there's nothing like good sleep. Okay, what about omalizumab? What's the trial? What are the trials that got it its FDA approval? That's Polyp 1 and Polyp 2, and then followed by open labeling after the first 24 weeks. So you can see on the left, the panel here, I have my pointer. There, this is placebo. This is about a little over a point reduction in the grade of the polyp. And then in the open label, everyone improves. And then when the drug is taken away, you start seeing the return to baseline slowly over a period of 24, the last 24 weeks. In terms of nasal congestion scores, same thing. It's about a 1-point improvement in nasal congestion score compared to placebo. In the open label trial, everyone gets drug. There's significant improvement, and then there's an offsetting of the effect afterwards. Mepolizumab, the SYNAPSE study was the study that got it its approval, showed significant improvement both in endoscopic nasal polyp scores, about 3/4 of a point if you take the average. But very interestingly, if you look at the data, you see there are some people who are really good responders. So that's the thing about MEPO, is that some people are really non-responders, and there's some really good responders. And so this is why trying to pick out who really are the people who are going to do the best. And we don't have the best biomarkers, but basically patients, when they respond well. And so there is a sort of a scatter amongst the responders. And the same thing for the nasal obstruction scores. There seems to be a large number that did pretty well. So again, and there are obviously some people who didn't respond, but the overall average numbers are good, and they were good enough to get approval. And the interesting thing is, when you think about MEPO and OMA compared to Dupi, these are my nicknames for these drugs, easier to say, that because they're not receptor blockers, there's a little bit more secondary action going on. There's a little bit more anti-inflammatory. So when you stop the drug, eventually, of course, if they follow these people long enough, everything will return back to baseline. But what they noticed in the MEPO study was that even up to 4 months after, 3.5 months after the offset of drug, there was still some therapeutic effect. So, the comparison's hard to make because there aren't that many. There's only one head-to-head study that's actually being done right now. That's that we'll talk about in a second. That's the omalizumab versus dupilumab study. There are a lot of differences in the heterogeneity amongst the studies in terms of how they were designed. But basically, omalizumab showed improvement in almost all of the studies compared to placebo. And it doesn't matter whether the eosinophil level was high or they had previous history of surgery. Dupilumab showed significant improvements across all outcomes, including smell, which is really very significant. And there's a significant reduction in the need for surgery and steroids, as well as the efficacy independent of whether or not you had high eosinophils or high IgE levels, or does it matter what the comorbidities were. And with MEPO, the main thing that's been shown is that there's a significant reduction in the time to need surgery, as well as improvement in severity of symptoms, regardless of the presence of severe asthma or AERD. So now the next 3 slides are kind of my opinion slides. I mean, they're based on data, but they're also how I practice. I get asked the question all the time, how do you choose between these 3 biologics? I mean, I like chocolate, I like vanilla, I like strawberry, but I have to make some decisions. And so I use this, this is kind of my little cheat sheet for how for and against each drug. So I think we'll go through this. Okay, so for dupilumab, if the patient has CRS with nasal polyps, things that make me tilt towards using dupilumab would be a higher tissue eosinophil level, and I hope that a lot of you are starting to look at the tissue density of eosinophils in your surgical specimens, because that often is an indicator for response to dupilumab, as well as are there any other comorbid eosinophilic and or steroid-dependent asthma. If patients do have asthma and they have high exhaled nitric oxides, which correlates with IL-13, that is usually a really good predictor of response to dupilumab. Do they have comorbid eosinophilic esophagitis or atopic dermatitis? After all, they are FDA-approved indications that we often see. And Most cases of AERD that are refractory do respond to dupilumab, so we certainly keep that in mind, as well as rapid regrowth of eosinophilic polyps after surgery. And usually I think of when the PBE is between 250 and 1,500 cells, that's a candidate. Now, if the PBE is greater than 1,500 cells, I start worrying about those patients. I really am a little wary about putting them on dupilumab because you do get a transient hypereosinophilia that occurs. Also, those are the patients that I'm going to be working up more closely for EGPA, as that's one of the criteria, is to have the cells above 1,500. And oftentimes you have to do more than one CBC. You're not necessarily going to find it on one. And EGPA is a difficult diagnosis. I mean, most patients don't get tissue diagnoses because they often are on steroids, high-dose steroids, by the time you see them, and oftentimes they're caught in a cycle of they can't get off steroids. And so this is why it's difficult to get a tissue biopsy. And so you have to have a high index of suspicion. You have to ask questions about neuropathies. You have to do some blood work, and you have to see, are the patients having these constitutional symptoms? They can't get out of bed. Are they having low-grade fevers, etc.? And then, of course, if the patient has comorbid urticaria, chronic urticaria, that would probably make me think against dupilumab and more for omalizumab. If they have systemic eosinophilic complications like eosinophilic pneumonia, or we've seen cases of eosinophilic coronary vasospasm syndrome associated with AERD. And the last one is, again, you won't find it much in the literature, but we did report adverse events to dupilumab in about 20% of the patients that we had on dupilumab. And it seemed like a lot of those cases were concentrated amongst women and the young to middle-aged women. Many of them had sort of autoimmune tendencies. And so a lot of them were getting that arthralgia-like syndrome. And so the thought is, again, that maybe we're shifting away from type 2 immunity, maybe pushing people who are prone to autoimmunity. Maybe we're pushing them in that leg of inflammation, towards that leg of type 3 inflammation. Okay, so what about the omalizumab, for and against? If they have very strong allergy skin tests or allergy blood tests to perennial allergens, if they have a really high IgE level, if they have allergic asthma, early onset atopic asthma, if they have allergic fungal rhinosinusitis or central compartment atopic disease, these are patients that I'm going to be thinking about omalizumab for. If they have the presence of chronic urticaria concomitantly, or they have something called the AERD rash, which is sort of a hyper overload of leukotrienes, leukotriene E4 and PGD2, where these patients get this pruritic skin rash. It's sort of like a hive, but it's not as raised as a hive. Typically, it's in the extremities, and omalizumab works beautifully in those patients. And what about my patients that are planning pregnancies? Omalizumab is the only biologic at this point that I will carry a pregnant patient through pregnancy with, and that's assuming they're doing well before on the drug because of the category B and the 21-year safety record. There's just not enough data on the other biologics, although they don't appear to be teratogenic from the early data, and hopefully with time we'll be able to recommend them more. But at this point I don't know too many people who are. So aside from the anaphylaxis of 2 in 1,000, that's really the only safety issue that I've ever seen with that drug. Again, some of the things that make dupilumab appealing, like late onset eosinophilic disease, low to normal IgE levels, not having a strong allergy background, rapidly regrowing eosinophilic polyps, and then difficulty getting to clinic because most omalizumab is administered at least early on in the clinic. What about MEPO? Well, we kind of talked about it in reverse. In patients who have high eosinophil counts, I'm thinking of mepolizumab early on. If they have systemic disease like EGPA, well, that's already approved at a higher dose. If they have a history of having had eosinophilic pneumonia or eosinophilic coronary vasospasm associated with AERD, if they're predominantly early onset allergic IgE, asthma, we're not going to be using that. And I'm not going to be thinking about MEPO. If their IgE level is high, if they have the AERD rash or CSU, if they have atopic derm. So just kind of the reverse of what I talked about. And the other thing is I find mepolizumab, it almost always works well for eosinophilic asthma. It seems to be more robust in terms of the response. But again, there are some really, individual responders in the upper airway that are out there, and we've seen them. The EBERS trial is the first head-to-head trial that's being done right now. Actually, should be completed very soon, and that's comparing omalizumab and dupilumab in patients who have both CRS with nasal polyps and concomitant asthma. And so that data should be in soon. Emerging biologic therapies include depemokimab, which is, if you could say that real fast, the Anchor 1 and Anchor 2 study. There was the asthma trial had very good results. This is an ultra-long-acting IL-5, anti-IL-5 therapy, one injection every 6 months. And so the data should be in soon, and they seem to have met their endpoints. So I'm anxious to see that data. And tezepelumab is a TSLP a blocker, and the same there. Results should be coming soon, and the endpoints were met. So moving along quickly, because we're running out of time, is the euphoria criteria, which Dr. Lee mentioned. There were 5 criteria that the expert panel, the European panel, found to be important for defining the response to biologics. The 5 criteria included nasal polyp size being reduced need for oral corticosteroids, improved quality of life, improved sense of smell, and reduced impact of comorbidities. If you had 4 to 5 of those, it's a good to excellent response. If you had 1 to 3, a poor to moderate, and 0 is no response. They recommend evaluating patients first at 6 months and again at 12 months. Of course, if they're in the red zone, you're going to stop that drug and consider other therapies. If they're in the green zone, you're going to continue. And if they're in the orange zone, you're going to make an individual decision with the patient. So what do we still need to know according to the expert panel? We need better biomarkers. We need to know how long to treat patients. Right now, everyone's thinking, well, it's forever. What's a remission? Is it a remission mean that they come off all their medications, including the biologic, or they come off all their medications with the biologic? What's the criteria for switching? What's the feasibility of spacing out the intervals? Because this is an expensive medication. If you're doing well, maybe you can do well on less medication. And the other thing is, where do you put biologics in the pathway? So we need better trials. And we also need, just as the focus of this meeting is, basically cooperation amongst the specialties and primary care and advanced practice providers to give the patient the best outcomes. And basically communication and collaboration is really the key. And so summary, CRS with nasal polyps associated with substantial discomfort, negative impact on quality of life. The condition can be refractory to traditional medical and surgical therapy. CRS with nasal polyps usually characterized by type 2 inflammation, 85% of cases. Asthma is a common comorbidity. Type 2 directed biological therapies approved for polyps, as well as asthma and other inflammatory conditions, include Dupi, omalizumab, and mepolizumab, with others in development. They can reduce nasal polyp size, improve quality of life, and reduce the burden of disease. And considerations for determining whether a patient's a candidate for biologics include the severity of the polyps and the degree of control with other treatment approaches, as well as the presence of comorbidities, which always need to be factored in. And with that, we are going to, do we have time for a case? We do. Okay. So here's one of my cases. A real patient, Harry, 35-year-old male, presents with 6-year history of chronic nasal congestion, excessive nasal mucus production, and hyposmia, intermittent episodes, dyspnea, wheeze, cough, which started shortly after his nasal symptoms. He treats these with occasional short-acting bronchodilator. His original CT scan showed homogeneous pansinusitis with nasal polyps. At an outside hospital, he underwent limited sinus surgery from which he did not derive much benefit. He was treated with several methylprednisolone dose packs. I hate the methylprednisolone dose pack, but that's another story for another day. With only minor and temporary improvement. Peripheral blood eosinophils 350, IgE 25, PFT showed mild obstruction, 78% predicted, with 15% FEV1 bronchodilator response, and an exhaled nitric oxide of 78 parts per billion, which is elevated. Allergy testing negative, aspirin challenge negative, nasal endoscopy showed bilateral grade 4 polyps. Treated with 1 month of oral prednisone starting with 30 milligrams and tapered to 0. We added a low-dose inhaled corticosteroid and LABA for mild persistent asthma. Nasal endoscopy after treatment showed grade 2 polyps bilaterally. He underwent revision FES at my institution with post-op oral steroids. He had a complete FES and a draft 3 surgery, 20 milligrams tapered down slowly to 0 for 6 weeks, and post-op debridement. He was started on high-dose mometasone rinses as well. The surgical pathology showed eosinophils greater than 100 per high-powered field. Charcot-Leyden crystals were present, and the fungal stain was negative. Over the next 6 months, his follow-up exams were never good. Polypoid changes were seen as early as 2 months. Post-operatively, only 2 weeks after stopping prednisone, he received another 10-day course of prednisone, which stated helped him for only 1 to 2 weeks. He was given a prescription for EDS fluticasone to administer after his mometasone rinses, more topical steroid. At the 6-month checkup, he had bilateral grade 2 polyps, was still anosmic, and said he was compliant. He was started on dupilumab 300 milligrams every 2 weeks, and at his 4-month follow-up, the endoscopy showed mild polypoid edema at the frontal recess and skull base. He had regained his sense of smell, and overall mood was happier. He continues to have good follow-up exams with minimal polypoid edema 18 months later. PFTs are normal, and exhaled nitric oxide is down to 27.
I'm going to go ahead and read out some of these questions, and we'll do our best to answer them. So the first one is from Samantha. Since Dupixent showed significant reduction in the need for surgery, what would be some reasons to pursue surgery first instead of starting biologic therapy first? And yes, we get asked these questions a lot. And there's really multifold reasons. And I know that in a lot of the slides, that's why I made sure to emphasize there were older studies. They seem to indicate that surgery was not effective, but that's not the case. As you saw, close to about 90%, if you do like some of the more neuroendoscopic approaches, they're actually very effective. So it's a one and done in addition to maintaining the postoperative topical steroid rinses. Whereas with the biologics, as you saw, it really is at least for as far as we know now, it's a lifelong therapy. So it's something that you would have to do essentially for, the rest of your life. If you would draw the biologic, at least for dupilumab, I think it was 10 weeks, maybe mepolizumab a little bit longer, your symptoms are going to return. So at least a lot of my patients a lot of these patients, like I said, are middle age, like 40 years old. They're not really too keen on the idea of having to inject themselves every 2 weeks for the rest of their lives. And with surgery, like I said, especially first time, and for whatever reason, and maybe Dr. Welch is here too, and some of the other rhinologists, many times when you do the surgery for the first time, it seems to be the most effective. Cases where I see it's just a one and done. You do the surgery, maybe they do their steroid rinses, and they're finished. So that is why in most of the algorithms, you'll see that we typically do surgery first and then consider biologics for refractory disease. Now, the second issue, which is an issue right now, is more the cost, right? So surgery, and Dr. Basso can comment on that. They've already done all the cost analysis. Surgery is the one and done. It's significantly cheaper than being on biologics for the rest of your life. So that's the reason. So it's a multifold reasons. But if there's anyone else who wants to chime in.
So let me just, a couple of points on that. We got cost, of course. The other thing is that Dupixent does, if you're a super responder, yes, you may get like 3 or 4 grades reduction in the size of the polyps. But usually you're only going to get 1 or 2 grade reduction. That's number one. Number two, if you're going to do surgery, go big or go home. Otherwise, it doesn't really pay, especially in the diffuse polyp patient. So the old days are where you just did a little mini polypectomy, and that's not going to work. So you have to have a wide surgery so the medication can be delivered. It's try to think of giving an asthmatic a topical steroid if they can't get the medication delivered to their lungs. It's the same thing. So that's important. And cost, that's obviously a concern. And the other thing is we don't really know. We don't have data on with the exception of omalizumab, we don't have 20-year data to show us what happens when you suppress, type 2 immunity for that long a period of time. Does it change? Does it push people into other types of immune pathways? We don't really have that data. So I think if you're fortunate enough to get a really good surgery and you have a compliant patient who's going to do topical steroids, and don't forget, if you have AERD and there aren't any contraindications to aspirin desensitization, that's still very cheap therapy. Okay, so and sometimes, and when it works, it works. If it doesn't, it doesn't. And so most people do get good results with that. But again, we had about 20% discontinuation rate. All right, let's talk about the next. Do you have any tips on duration and discontinuation of dupilumab for a patient? Well, the other problem with discontinuation is that a lot of patients lose their insurance, change their insurance. What I see is every year and a half to 2 years, they're on, they're changing their insurance plan. And during that time where they're trying to get reauthorization, the polyps can regrow. So if the only thing you've done is dupilumab and you haven't done a surgery, you haven't really done anything else, you're going to see recurrence sooner than later. It is just a receptor blocker. And so when we did the studies, although it really works well and it can work very quickly, it also has an offset that's faster than some of the other biologics.
I know this is a little bit of a tangent, but,
You're allowed.
I mean, I know it's always, the discussion is always about biologics or surgery, but at the end of the day, chronic rhinosinusitis is an inflammatory condition, and we've always treated it with a combination of surgery and medical therapy historically. And, that's why I think there's ongoing studies to see if, and I've seen in my own practice, like those patients who have a combination of biologics and surgery do absolutely amazing. I mean, their cavities are beautiful, whereas if you do one or the other, there's a chance that it's not going to be quite as good as both. So we'll just have to see how it plays out. But of course, like Dr. Basso said, we don't really know 20 years from now what's going to happen to these patients when you suppress their type 2 response for that long, what type of potential adverse effects may emerge from that as well. So there's still a lot of uncertainty. And at the end of the day, if there's no comorbid conditions, this is a localized disease. So if you can treat it in a localized manner, that'll probably still be better than kind of, essentially releasing a bomb into your whole body, right? Systemic therapy.
I mean, I'm forced to go to biologics sooner when a patient has a strong comorbidity.
Exactly.
I mean, obviously, if they're severe asthmatic you can't control, you're going to go to a biologic sooner than you would, even before you would consider sinus surgery or whatever. So that's a situation where if the comorbidity is more serious, then you're obviously going to handle that. And if the patient's not responding to standard therapy for that condition, and that condition is really, putting them in the hospital or really dramatically affecting their quality of life, then I think you're going to go with the biologic first. So I do think you have to you just can't think of polyps as almost everybody who has CRS with nasal, not everyone, but there's a large number that have comorbidities or other circumstances that may lead you to one versus the other.
It's highly individualized in some ways.
And exactly. It's not a
personalized case.
And I think, to Joseph Engelfeld, should other indications drive your decision on choice, or should you use biomarkers as a main priority? I think I hope I covered that in my green and red thoughts about not just biomarkers. Biomarkers were on that list, but the other thoughts were, what about, the level of the other comorbidities, which ones are, or maybe has patient tried other therapies and failed them, and how far have they gone? So there are definitely I think it's a combination. Do biologics affect response to allergen immunotherapy? Well, omalizumab does. Omalizumab certainly has been shown to dampen down the effect, and it is easier to immunize someone who has very, very strong skin or blood test sensitivities. While they're on omalizumab, there's some patients you may bridge, again, assuming that allergy is driving the sinus disease. But if in that situation, you may use omalizumab as a bridge to get them to a maintenance therapy. So we've done that. Any others? We have more.
If patients are well controlled on biologics, do they need to continue on intranasal steroids? I have to say a lot of my patients stop their steroid irrigations, especially the budesonide, once they're on biologics, because they're doing so well. These are the post-surgical patients.
If they're having a great response, and then they'll use it less, and that's just something that. Go ahead.
Let's see. Diana says, do you foresee that there will be efforts to investigate the ability to maintain effectiveness of biologics while increasing the time between dosing or prescribed for a specified period of time to reduce potential financial burden? I do think that's the case. I think there are ongoing studies to see if you can increase the interval. It's a little bit, I think, harder to do in the US just because it's not FDA approved to increase the interval. But I have a lot of my patients that sort of auto taper themselves. Some of them can tolerate it and some of them can't.
Went to use Dupixent and Tola. You mentioned elevated FeNO when you believe a biologic targeting. Do you believe a biologic targeting IL-13 and TSLP would be beneficial for this population? Well, certainly, yeah. I mean, I agree. I mean, if IL-13 is the driver of exhaled nitric oxide, yes. And TSLP, well, that seems to work for the asthma that is either type 2 or non-type 2. So, but the polyp data is not in yet, so we haven't seen that, but it should be released soon.
Dan, what are some ways you attempt to wean patients off of biologics? Really good for you. For us, it's like I said, it's an auto.
I think it's a flow. If someone's doing super well and they maximize the other, they're compliant with their other medications. You can very slowly try to space out the interval, follow them up, make sure they're not losing anything, they're not rebounding on you. It really is a trial and error kind of situation, where again, those super responders, you see someone that come in, everything is great, and they've stopped those other medications, and then reintroduce some of the medicines that they've stopped, so that maybe they can expand the interval. Sometimes they feel so good if they're a really good responder, they may be so good on the biologic that they've abandoned the other medicines. But then, maybe that's not such a good idea if you want to space out the biologic. So that's where, that's a little bit of art, with the science.
So Stephen, how can we best conjugate surgery with biologics like perioperative usage? Surgery itself is also a type 2 reduction effect. I mean, that's absolutely true. And I think that's why it's a subject of ongoing investigation. I'm hoping that in the future we will have an algorithm that is more, I would say it's more complementary as opposed to binary. And I think it's because the cost issue is what's making it mutually exclusive. But I can't foresee a situation where, the biologics can actually help the surgery make it easier, maybe less bleeding, similar to we give perioperative steroids, right before surgery for a lot of our polyp patients. And it reduces the inflammatory disease burden when we're actually doing surgery. And I actually had someone who was on a biologic for a different indication, like you said, really severe asthma. And when we took him to surgery, it was easier for me to do it, I think, than if I had to just do it up front. So
I mean, yeah, there are different ways you could use. You could, if you're going to use them, maybe temporarily to spare some steroid in order to get a better result. That's an option. What % of patients with CRS with nasal polyps, NOS, who have greater than one complete ESS and are adherent to its steroid irrigations end up requiring? I think you showed that slide. It's about, I mean, if you have a good surgeon, and all our rhinologists are great surgeons, and patient is we're seeing maybe 10% of those patients.
Yeah.
Really, if you're getting too much higher than that, if you're going much higher than 20, maybe the patient's not doing the irrigations correctly. Maybe the surgery was not complete. There's now Jim Palmer introduced a completeness of surgery index that's now, that's something that we may start using in the future to get an idea of whether patients have had what's quote unquote a complete enough surgery. This is all to be determined.
I think that's critical because I think one thing as we do these, multidisciplinary conferences and sessions is to try to kind of explain that not all surgery is created equal. And if we have a way of sort of defining or categorizing the extent of surgery, they'll be kind of easier also to stratify indications for biologics.
Alex, is there data on spacing out the biological therapies more than the current regimens? The answer is no. Not yet. Whether it'll happen or not, I don't know. I think for some reason there always seems to be some hesitancy doing those studies, and I'm not sure why. But maybe we are pushing for that to be done. So I'd say that the community, the ENT and the allergy community, is pushing for that to be done to try to see if if once a patient's stabilized, we can get some cost effectiveness. Does starting someone on a biologic prior to surgery affect the long-term outcomes of surgery?
I think we don't really know the answer to that quite yet. As I mentioned, just anecdotally, it may actually make the surgery easier up front, but in terms of long term, I don't think it would adversely affect it. But we'll just have to wait and see. There's still a lot of studies that need to be done.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent medical education grant from Regeneron Pharmaceuticals Incorporated and Sanofi. To access all materials for this activity, visit peerview.com/NMD860.